Question 16, we've got a doozy for you. Which of the following is the most likely cause of her symptoms? Ovarian torsion, acute appendicitis, nephrolithiasis, placental abruption, pyelo. Okay, so either renal or repro, it seems like. Starting from the top, a 28-year-old woman gravid a 2-para-1. Literally, by the way, I always ignore that. Currently 24 weeks pregnant, presents to the emergency department with 6 hours of right-sided abdominal pain and flank pain. So she's 24 weeks pregnant, 6 hours, so it's acute, with abdominal and flank pain. So just right there alone, flank pain should be cueing in on something renal. She says the pain began gradually and has been worsening. She also feels nauseated but not vomited, nice vaginal bleeding. Okay, this is important too. No vaginal bleeding, leakage of fluid, or trauma. So that might help us rule out uterine causes or vaginal causes. She has had 2 bouts of cystitis, right? So 2 episodes of a UTI already, and they were resolved with medication. Fetal movements are normal. Vitals are within normal limits. She's a little tacky. That's okay. Physical exam reveals tenderness to palpation in the right mid-abdomen and right flank. So right mid-abdomen, right flank. Again, still thinking renal. We've got this whole renal setup. Flank pain, the cystitis, history, more flank tenderness, no rebound or guarding. UA is unremarkable. So let's think this through. We'll start with probably one of the important things here with vaginal bleeding. There's no vaginal bleeding or leakage of fluid. So placental abruption right away should be out. That doesn't make sense. Next up, ovarian torsion. Okay, ovarian torsion, that would be acute. It would be unilateral. Ovarian torsion, I'd say this is a little suspicious. I mean, I don't think we should rule out right away. This might present with vaginal bleeding, maybe, well, probably some adnexal tenderness, but I don't think they did a bimanual exam, so there's no way to know for sure. It is just mid-abdomen, right flank. I'm going to put this on the back burner because I'm not totally sure. And that's how you should be thinking about these sorts of things. What about nephrolithiasis? That's kidney, so that could be right flank pain. It could be. I'm not going to rule this one out either just yet. What about pyelo? Pyelonephritis could also be very similar. So this is a tricky question because we have quite a few that are kidney, right? We have the history of the cystitis. We have the flank pain. So nephrolithiasis, maybe history of cystitis. I'd be more inclined to think pyelo than nephrolithiasis just based off of our history alone. But what's really interesting here, and we didn't highlight it in the first pass because it's so easy to miss, the UA is unremarkable. How are you going to have stones without hematuria? How are you going to have pyelo without possibly hematuria, if not white blood cells, maybe even casts? She has a low-grade fever, sure, but that really doesn't mean very much if the UA is clean. So that's how we rule out pyelo and nephrolithiasis. That's what's so tricky about this, is you really have to read very carefully, and they do this on tests too. You have to read very, very carefully because they hide information. Sometimes it's just one sentence. That's all you need. So between ovarian torsion and acute appendicitis, let's think about it like this. Here we've got this diagram that I drew out. Fantastic diagram. On your left here, we've got, let's say, a non-gravid uterus or maybe very early pregnancy. The dark red lines represent the diaphragm on top, and then the peritoneum separating the uterus, the pelvic cavity from the abdominal cavity. So very early on in pregnancy, we have something like this. You've got your adnexa here, your appendix here. And so we're used to seeing right lower quadrant pain for appendicitis and probably also ovarian torsion, although usually ovarian torsion would be a little lower, right? More like pelvic pain, not so much right lower quadrant, but it could be. It could be. I wouldn't rule it out just because it's not exactly fitting your specifications. Now let's check out a gravid uterus. On your right, now we have this big uterus, and look what happened to the appendix. Cross-section this for you, kind of divided up into the quadrants. Now, instead of being in the right lower quadrant, the appendix is in the right upper quadrant, right where you could be having flank pain, mid-abdominal pain, unilateral mid-abdominal pain, I should specify. And even the adnexa is also higher now too. This is the way I've drawn it. It's still right lower quadrant. Out of these two, I just think you might expect to see some hemorrhage, maybe slightly more inferior pain. But again, gravid uterus could push them both up. I'm going to go off of them not mentioning adnexal tenderness as the reason why we should lead with B here. Sometimes they do that. They just won't say things, and that's okay. If they had told you that there was no adnexal tenderness, then it would just be more obvious. But we can still make the assumption here that based off of where the pain is, it's a little higher up. It's honestly, even with a gravid uterus, I still think it's a little too high for our ovarian torsion. And torsion is even typically a little more acute of an onset and can present with more nausea, vomiting. But I do want to point out there is no rebound or guarding. This was just here to help throw you off the trail even more. They can say anything. In these test questions, they can only ask you certain pathology, right? There's only so much pathology to ask you about, so they have to change up the questions, hide things, make them more vague. And it's questions like these that are tough but doable if you use logic to try and work your way through it. This was important just to really think about the gravid uterus moving things up during pregnancy. I've seen questions like this before. An additional reason for why not ovarian torsion is usually they give you some history about kind of like a lead point for intussusception. They usually tell you about adnexal cysts or masses, something for the adnexa to get torsed around, something to cause this torsion to happen in the first place. And we don't have anything like that. And our fetal heart rate is 145 per minute. So that's under our 160 over, I believe, 110, and reassuring. So all the more reason, probably not something uterine or nearby related. Correct answer is B.